Thank you for joining me today. I'm really pleased to be here again with the Parkinson Association of the Rockies. My name is John Dean, and I'm a speech-language pathologist. I've been specializing in and working with people who have Parkinson's for about 20 years or so now. And today we're going to talk about swallowing changes, difficulties with swallowing that are associated with Parkinson's. It's a pretty common concern. And I'll go over the slides as we're going in here, but again, as I was saying to people as they were coming in, don't hesitate to unmute and ask me your question or put it in the chat. I'm happy to talk about literally anything. I do a lot of work in this area and I try to keep up to speed. So I think without further ado, let me go ahead and just start the slides here. Today's session, we're going to cover a couple of different topics. We're going to begin by discussing what a problem with swallowing looks like in Parkinson's. How do we identify them? How do clinicians identify them? How can you identify them so you can tell your doctor about it? Then what we might do to treat things. I'll go over quite a bit about how to make meal times better, because I think that's really where the functional things are necessary, so you can make it easier to be with friends and family and make sure the meals aren't taking too long. And then I'll talk a little bit about how to improve the way you swallow meds. Pill dysphagia, as it's called, is a very common issue, and it's something that I think many people report having problems with, especially early on. It's one of these things that happens pretty early in the diagnosis of Parkinson's. So again, I'll start probably with the basics of what a swallowing problem looks like, and to do that, I think it's important to identify what a normal swallow looks like, what an issue with swallowing might look like, and then talk about the way that components of Parkinson's, the motor and the non-motor components, might influence that. So typically speaking, there are three primary stages of swallowing, and then I add in the pre-oral, which is really everything from the table or the plate to your mouth. So that's not exactly a swallowing issue. Typically, if you're having issues getting it from a plate to your mouth, I'm probably looking at an occupational therapist to get involved to help us, although we do cross-pollinate quite a bit. A lot of OTs are actually quite good at swallowing issues as well. That leaves the oral phase, in which the food's in the mouth and you're chewing it and you're preparing it, and maybe you're moving it around with your tongue and you're getting ready to swallow it. And when you do that, you form what we call a bolus. You take the food, you make it into a little ball, and you push it towards the back of the mouth. Once it gets past this area here into the pharynx, that's the pharyngeal phase. You're actually now starting the process of moving it down into the food tube of the esophagus, and this is usually where we have to be most cautious. This is where problems can happen and food can get down the wrong pipe. And then the esophageal phase happens here, right at this point where there's a sphincter that opens up and the food goes down the esophagus. And in that situation, that's mostly autonomic, mostly happening involuntarily. So obviously if I'm chewing and I'm closing my lips and moving around my tongue, that's 100% volitional. And then once I start triggering the swallow, it starts off volitionally, but eventually becomes involuntary. Once it starts going, it's hard to stop that. And then the esophageal component is the part where there's very little volitional muscular control, but you do hear of a lot of issues at the esophageal phase with food feeling like it's getting stuck, or particularly when people have reflux. So just a really basic definition. I cut this way back. Just anything that is happening abnormally from liquid and food in your mouth getting into your stomach. That's dysphagia. That's a swallowing problem, and there's a lot of different ways you could define where it's occurring or what the basis of the problem is, but let's just keep it pretty simple. There's a lot to cover in that area. If you look below, there's a wide variability in what we call incidence, or the amount of people dealing with a swallowing problem in Parkinson's, and there's a lot of reasons for that. It's one of these things where the way that swallowing may be defined varies between different researchers, and we've made some progress in standardizing that, but there's still maybe some variability in the definitions. And another really common thing is that oftentimes swallowing problems, at least the kind of swallowing problems that bring you into your doctor's office, they typically occur pretty late in the Parkinson's. It's not an early appearing symptom, although many people report having difficulties with pills early on, having pills feel like they're getting stuck or making it hard for them to go down without having a little bit of extra food or liquid. And so I wouldn't worry so much about where the numbers are, but it's common enough that I think that it's something that should be on your radar and you should be able to identify it. And you really want to address it because swallowing issues, in addition to, in reducing enjoyment and benefit at meal times, can lead to pretty serious consequences. You can have bits of food or liquid in your mouth get into your airway and it can lead to pneumonia. And if you're having real difficulties getting the food down, you may have some malnutrition because you're not getting enough calories in. And so let me break down a couple, using that same graphic, let me break down a couple of things that you might see appearing if you are living with Parkinson's and you're starting to have swallowing problems. And again, I'm going to leave the pre-oral part of that out here for now because that's really about motor control, about getting something here to here. In the oral phase, the things that I'm looking for are when you're chewing and you swallow, after you get done, do you have bits of food in your mouth? Do you have what we call residues? Sometimes they pocket into little areas, where the teeth and between the gums and the teeth or the jawline there, or sometimes it can just be bits in little crevices. So those residues tell me that maybe when you're using your tongue to form the bolus, it's not perfectly formed and maybe the tongue on one side is a little weaker. Typically in Parkinson's, it starts on one side and eventually over time becomes bilateral. How fast that happens is highly variable and can be influenced by a lot of things like exercise. But if you're seeing that, usually you're going to see it on one side more than the other. It's going to be the side that has more impact from the Parkinson's. Difficulty triggering the swallow. So your tongue actually comes up against the roof of your mouth and makes kind of an airtight seal. You hope it makes an airtight seal. And then as that happens, it becomes something that becomes automatic. And so sometimes that can be impaired as well. That could also be because the seal isn't perfect and you're not giving the proper information, neurologically to your body that says, I'm ready to swallow, because it can tell that you're not. Maybe even the back of your soft palate's not coming up the way or it should, or other components. Sometimes, too, you can have food spilling out of the front. There's drooling, which also happens in Parkinson's, but even just little bits of food getting past your defenses. The good part about this is extremely treatable. Working with a speech-language pathologist, they'll be able to do exercises that will strengthen the musculature and improve performance there. And similarly, if you're dealing with the next part, the pharyngeal phase, where you're basically traveling from the back of your mouth into the beginning of your esophagus, what happens there is this flapped skin here called the epiglottis will flip over and protect the airway and then makes a smooth passageway for the food to go into your esophagus. And again, if these muscles are not firing with the level of force, if they're not as strong as they should be, or maybe the hyoid bone's not coming up to make it an efficient action, these are other areas where a speech-language pathologist can help strengthen and produce better performance. And then finally, with the esophageal phase, it's the one where I have the least amount of tools to really address things, because it's mostly involuntary. I don't really have exercises, but there are ways that you can address it by being careful with how much you're eating at one time and how big a bite you're taking and things like that. One thing that's interesting with esophageal issues is that if you're dealing with some GERD, some gastroesophageal reflux, sometimes that'll refer and it'll feel like you have what we call a globus sensation, where it seems like something stuck up here, but it's actually irritating the nerves farther down and referring it up there. And similarly, sometimes you can have a hoarse vocal quality and it's actually irritation from down there. Occasionally, if you're unlucky, you can have acid from the stomach going up into the esophagus, and if it gets really far along, it can get into the pharyngeal area, into the part above the airway, and lead to issues. I don't see it very commonly, but occasionally you'll see a situation where reflux is getting all the way up in the esophagus and then getting into the vocal folds and irritating them and causing issues. And when you deal with that kind of problem, that's called laryngopharyngeal reflux, or LPR, that's usually going to be addressed better with a doctor and with diet. There's no exercises I have for that. Now, being specific to Parkinson's, there are components of Parkinson's that will either cause or usually just exacerbate the swallowing problem. So when you look at the hallmark, the key elements of Parkinson's, you have slower, smaller movement, you have some rigidity of the muscles. Oh, someone's got it. Okay. Someone's asking a question about probiotic. I'll get to that. I'll add that in there, but thank you. I'll add a piece into that. So when you have the components of the Parkinson's affecting the structures of the swallowing, it's going to have a similar influence. So when you have slower, smaller movement and you're walking, that means your steps are smaller. And when you're writing, maybe your handwriting is getting smaller. That's really common. And when you're talking, your voice gets quieter. These are all common Parkinsonistic aspects. And when you apply that to swallowing, then that means that maybe the amount of effort you're using when you're bringing the tongue back isn't enough, and maybe some of the food is not moving as fast as it should because the airway is not sealed. When you swallow, a lot of it's pneumatic. You're moving the tongue, you're using muscles, but you're actually making a seal and using that air pressure to pump it down into the right places. Not entirely. It's a system, so there are a lot of components to it. And so if something's not giving you a perfect seal, now you're not getting that movement as much as you need. And this is where the aspects of Parkinson's can influence that. And I like to say typically that whatever you can see happening in Parkinson's, whether it's your changes in facial expression or changes in your handwriting, happens in places you can't see, and that definitely has an influence on swallowing, just as it does on voice and other aspects. Now, some of the non-motor symptoms, and non-motor simply means the ones that aren't related to movement. They're usually ones that don't do well, don't have improvement with medications. You take a Cinemed and your movement ability is going to improve pretty dramatically, especially when you first start taking it. It's be the nice honeymoon. That's not going to be the case so much for non-motor symptoms, and changes in your sensory components like your smell, or maybe how well you're able to actually feel and have sensation in your mouth and in different parts of the swallowing. There's even changes in cognition, and that could influence your ability to swallow properly. Maybe you get distracted when there's noises around, or people are talking or walking by, or whatever is happening there. And then finally, if you have depression or anxiety, and it's pretty common in Parkinson's, that can cause distractions that will make it look like you have cognitive changes, but you don't. It's actually just the depression speaking at that point. And so medications for that may be effective if you talk about it with your doctor. You also have to worry about some medications causing dry mouth, and maybe that'll influence how well you swallow. I want to say that most of the dopaminergic kind of medications, the typical Cinemeds and dopamine agonists, that's usually not the issue. It's usually older classes of medications, and sometimes medications you might be taking for something else, like an over-the-counter allergy pill may have some influence on dry mouth, and that'll have some influence on swallowing. Just to kind of keep this simple and break it down here, because I'm getting a little bit into too much information here. This is a nice chart where you can kind of break down things and see if you're seeing any of these issues in you. And if you are, this is a good reason to make contact with your doctor, whether that's calling them up or getting onto my chart or having a visit with them, and seeing about getting a referral for a speech therapist to do swallowing treatment, or at least a swallowing assessment. So drooling, if you are someone who drools, you automatically have a higher risk. It doesn't mean you have a swallowing problem, but it's something, as a speech language pathologist, if you're coming into my clinic, I'm going to be looking at you a little more carefully. I'm going to make sure I do a really extra good bedside evaluation, because I want to make sure I'm not missing something. And some of this has to do with the people that have drooling more frequently have a particular phenotype, but all of it is just you got more liquid going around and you're not controlling it as much. It makes it likely that some of that liquid might get past your defenses and get down into your airway. Weight loss, and I'm not talking if you're taking, the new Wegovy's or something like that. If you're trying to lose weight, that's one thing. But if you're not trying to lose weight and you're losing weight, that usually means that maybe you're having more difficulties at meal times. And what's causing that? Is that a situation where getting it from the plate to your mouth? Okay, that's one problem that we can address in one way. Is it how long it takes to chew it and swallow it? Okay, that's another issue. And there can be other factors involved in that weight loss too sometimes. But if you're having weight loss, don't sleep on that, because it does put you at risk for a lot of other issues. Now, when you cough, when you're chewing something and you're getting ready to swallow it and you start coughing, that means that something, usually it's liquid, but it can be food, has gotten past your natural defenses. Your tongue, when you swallow, your tongue comes back up here and provides a little barrier, and then the tongue comes up in the front and it moves it back. And so if you have pieces going over that little back of the tongue, which is very common, that the tongue won't elevate the way it's supposed to, then your body's natural defenses will kick in and cough to prevent it from getting in your airway. Now, we all do that. I'll do that. My wife will do that. But if it's happening more frequently, and I would say even more than once or twice in a week, then that's probably the beginning of something, and it's early, which is a good time to address it. Don't wait till it becomes something where at every meal you're coughing. Along that line too, if you're having an unexplained infection, if you're having fever and having a respiratory infection, that could be the beginnings of some pneumonia. And again, that's really what we're trying to avoid. Pneumonia is probably the most serious consequence associated with the swallowing problem, and it's why you should be aggressive in addressing it. You don't want to wait for that, because pneumonia could really it could put you in the hospital, and it could really set you back quite a bit, and it's very dangerous. Falls are a really big issue in Parkinson's, and they lead to a lot of problems. And I would say pneumonia is probably the second on that list. Falls are the most important. Pneumonia is a close second. So again, if you're looking through this list and you're seeing anything here that's like, oh, I'm having this problem, or it does seem like I'm taking longer at meal times. Oh, it does seem like I'm not keeping my weight on. Talk to your doctor. There's no reason to not ask them a question about this. And the doctor will come and hear your symptoms and write a referral, and you'll work with a speech language pathologist. And the first thing you'll do is you'll come into our clinic, and we will, I'll do a little assessment, an oral motor exam. I'll probably try some foods with you. And this is what's known as a bedside swallow evaluation, although usually if you're going to an outpatient clinic, so it's a clinical bedside. And that gives me some early information. I can try some liquids. Liquids have a tendency to go down through the path of least resistance. So if you're going to cough on something, you're probably going to cough on a liquid. And it gives me some early data that says, okay, definitely an issue, or I'm not sure. The problem with a bedside swallow evaluation is that they're limited. I can't really see what's happening. I'm relying a lot on my clinical expertise. And so if I don't work with a lot of folks who have Parkinson's, that might not be as valuable as it could be. And so there's a lot of issues with a bedside that would say to me, unless I had to rely only on a bedside, and I've been in environments where that is the case, but it's not that much anymore, and I certainly would avoid them if I could, you're probably going to get an instrumental exam at some point. Remember back when I was talking about how there's a wide variability in the incidence according to researchers? Some of these studies relied on bedside swallowing examinations, and that's part of the reason why maybe things were missed that wouldn't be missed. So when I say an instrumental examination as being better than a bedside, it's really the gold standard, and we're looking at it in two different ways. You can do what's called an X-ray swallow study or a modified barium swallow study, and then you can have a fiber optic endoscopic evaluation of swallowing, or FEES. And both of these provide me with direct visual information, and that helps me a lot. The FEES gives me a little bit less because I can't see below the vocal folds, but it's very viable. but it's still pretty much a snapshot. So it's only this time when I'm working with you. Oftentimes people, when they're coming into clinic, you're on your best performance, you're optimally medicated, you're sitting upright, you're using a clear voice, and so sometimes that snapshot isn't perfect because you'll look better than you really are day to day. I would almost love to be able to do one of these, when you woke up in the morning before you had your first cup of coffee. Now I want to see how things are going. So instrumental examinations are very valuable, but there's still things missing. But it's the best we have at this point. And just to give you a little more on this, what would happen for a modified barium swallow study is you would come into an x-ray suite. We would mix up some food with this paste, this barium paste. Doesn't taste too bad, it's fine. I've eaten everything, it's all fine, but it looks a little funny. And then we just put it in there and you eat, and then we watch it with an x-ray with a video, and we can see the food going, and I can see if it's going into the wrong areas or if you're having difficulty getting it started, the swallowing started, or any other issues like that. And I can even see go all the way down. They usually do that at the end of them in our clinic, where you'll actually see the front part of it. And you can see if there's any issues in the esophagus. Although if you really have that issue, we would refer you to somebody. So again, it's a nice way to see things. It's been around for a long time, but more recently. I beg your pardon. Oh, do I have my video in here? Let me show this here. I didn't think I had my video in here. Okay, this is what's happening. So here's an individual. You see that black stuff? That's there, the bolus, and you can see there's a little bit. It's a little bit slow, and there's a lot of residual right above there. At the bottom here, above the esophagus. And in this area here, this black, that's all liquid, and it's pooling in an area that worries me a little bit. Of course, this video stopped, so this person's not holding it there like that. But if you have liquid like that, that would tell me, like, well, that liquid's going to go somewhere, and eventually it's probably going to go into an airway if you're not careful. And then the other one, this fiber optic endoscopic evaluation, the FEES, they put a camera in through, they put it in through your nose. People get scared about that, but again, I've done all this. I actually went to an ENT and got a FEES, and I'm just making sure I got another one in the chat. And basically they put the camera in there and they look down from above, and then we'll give you some food and liquid, and we can see the swallowing, we can see if there's any residuals. Again, it doesn't let me see below the vocal fold level, so there's things below that I might not be seeing as well, but it gives me an awful lot of information. And actually there's a therapy that you can do where we use the camera in conjunction with the food, and it's got pretty good evidence. It was originated in Israel at Ichilov Hospital, but typically we just use them for evaluations. Okay, someone asked me, does coughing due to choking on saliva fall into the choking on food or drink category? Yes and no. And I'll say this, coughing anytime on any liquid, whether it's you're drinking a sip of something, I have my water bottle and I maybe move too fast and it gets past there, that's definitely happening when you're drinking a thin liquid. But if you have saliva in your mouth and maybe you're not managing it as much, you're not swallowing it as frequently, which is usually what happens, then you'll have a buildup of it and it'll get past your defenses. And so the easiest thing to do for that is to remind yourself or remember to swallow more frequently. I'll actually talk directly about that at the end when I talk a little bit about drooling. But yes, so aspiration, as we call that, of any kind of liquid, whether it's your saliva or your liquid that you're drinking, it's an indication of a swallowing issue that you can probably address. I'm just wondering why they only went to one side and go to the other. I was looking for the chat and I have them in two computers here and I didn't see the other one. So sorry I missed that before. Here's something here. There we go. Very good. Okay, so now I'm going to talk a little bit about how we address swallowing problems. And generally speaking, we're either going to exercise, we're going to strengthen the musculature, we might strengthen some of the airway musculature, and I'll talk about this more in a minute, or we'll compensate by either giving you ways to eat more safely. We can do the chin tuck. You can take a sip of something and tuck your chin down, and that helps by bringing your epiglottis forward a little bit. or maybe we'll modify the food a little bit. We'll make it a little softer and easier to eat. I have to say, thickened liquids, I see them occasionally. I just saw the Royal College of Speech Language Therapists in England, their society, like we have ASHA, they have the RCSLT. They just published a position paper on it, and they're not very positive on either. So I don't usually like thickened liquids, but we can still modify things a little bit to make it a little easier. So again, if I'm strengthening specific swallowing muscles, if I'm noticing issues here with the tongue, maybe not clearing things properly, or maybe you're not getting a good airway seal, or maybe the back of your tongue, it doesn't seem like it's coming up all the way, and it should be, so that it protects while you're chewing, the back of your tongue holds things back, it guards it a little bit. Those are exercises that we can do as a speech language pathologist to strengthen that up and get you back in shape. This expiratory muscle strength training is very interesting because it's a very non-invasive, easy activity. It has a device that has quite a bit of evidence to support it. Actually, I don't know how many articles by now, probably at least 10 or 12. I mean, quite a number of articles going back more than a decade. And I'm just going to mute somebody real quick here. Yeah, one hot second, folks, here. There we go. And initially, when they were doing this research, obviously they thought, hey, we're going to practice strengthening voice production, or breath production, really, the airway, and that actually would lead to better voice production. But initially, they didn't see that. It only took a while before some more research came out. But what they found quite quickly was that because you're working very hard to push out this air, you have to produce a nice strong embouchure, a lip seal, and then you got to recruit all these muscles. Well, lo and behold, that showed quite a significant benefit for swallowing. And I'd say that's my go-to for people, is using a threshold trainer like this can actually have a real benefit for both now, but certainly for swallowing. And before, I was talking with someone who was dealing with some COPD kind of symptoms, or maybe other airway kind of symptoms. And I would say before I would do this without, I would talk to my doctor to make sure that it's not contraindicated. But for most folks, it's a pretty good approach. There are two kinds of devices. Actually, this article just came out about 2 weeks ago, so I just added it in here. There are ones that are basically resistive trainers, what they're calling flow resistors here, and then threshold trainers. And a resistive trainer has a little baffle inside of it, and you blow, and the harder you blow, the more resistance you get. The one that you'll see almost all the time is the breather, and it's fairly popular. And then the ones that have a threshold means that they're carefully calibrated. You have to get to a certain amount of pressure before the one-way valve opens up and lets it out there. And I've always been biased towards a threshold trainer just because they have better data research-wise, but also I think that I see my people with Parkinson's often, you can kind of cheat the resistive ones. If you don't push really hard with a full effort, then you don't get the resistance you need. And sure enough, this article came out. They grabbed a whole bunch of these devices, and they showed that not only did the resistive training devices have a much lower starting point and ending point, between like 2 centimeters of pressure up to maybe 15 or 20, where the green one on the bottom starts at about 5 and goes to 75, and the blue one on top starts at 30 and goes to 150. They also have much better calibration in between, so there's different settings and you can make it much more precise. Again, I would say still talk to your doctor, or if you have a relationship with a speech therapist, and you all should, talk with them about it. They might have their opinions about why you would use one or another, but I do think this is a very good thing to integrate into your routine. It's pretty simple. You just do 5 little breaths with a little break in between there, and you can do that several times throughout the day. I think the protocol is actually 5, and it's easy to do. I actually still use these devices myself. I still work with them just because I like to keep in shape. So after you've gotten through some exercises, things that you can do to strengthen, now you start looking at how you compensate. And I mentioned a chin tuck. I'm not going to demonstrate it here because a chin tuck is a way to improve your safety with liquids. But research using instrumental examination shows that it's not universal, and not everyone should just, like, you get a chin tuck and you get a chin tuck. You should work with your therapist and assess whether it provides benefit, because if it doesn't provide benefit, you could be doing something counterproductive. And it might be a situation too where there's certain foods, heavier, harder foods, you're making the passageway smaller, so you wouldn't want to use it. So you should probably work with a clinician to get trained on that. But then the other way I like to compensate is to modify the foods that you're eating. And if you've had to spend any time in a rehab setting, like overnight or whatever, that may have not been the best experience for modifying foods. And I'll just say that there are much better ways to do that, and you don't have to rely on the way that they do it in institutions. And so I think the first thing I do is try to find foods that are naturally softer, maybe naturally more moist. And so pastas are easy, squash, baked squash, mashed potatoes, beans, avocados, bananas. I like casseroles because they have a lot of moisture in them and they're usually softer. You got to be careful if they have something really hard in them, like if you got carrots inside or something like that. But find foods that are naturally softer. Sometimes I'll cook them in a slow cooker, or I'll put them in some kind of cooking method, Magic Pot, Instapot, or something like that, that makes it a little easier to eat as well. You can also do this with some prepared foods and things that you might not think of initially. So like a pork chop, that's a lot. That's almost like a piece of steak. That's an intact meat. It's a lot of work. You got to cut it. It's a lot of work. Then you got to chew it quite a bit. That's a lot of work. And then you swallow it. And it's not as easy if you were to use something like a pot roast or a meatloaf or even a package of pulled pork. And then any kind of softer prepared foods like chicken that's been cooked, or tenders or something like that. Those are all easier ways to eat. And some of them actually have the benefit of being finger foods, so they're a little easier to get from your hand to your mouth. It's one of these things where if you start looking at the grocery store, you'll see, oh, there's a lot of opportunities here. Here's sausage, and here's chicken tenders, and here's a meatloaf that I can eat pretty easily, and I don't have to work so hard to cut it up. You'll see a lot of options there. And then you'll also have a situation where you can make the food a little moister, and that also helps. If you don't have enough mouth moisture, or maybe the food's a little bit dry itself, then if you can add a condiment, if you can add ketchup or mustard or some other sauce, maybe even you can add a little bit of oil to it. Olive oil is very good with potatoes and items like that. That'll help make it go down a lot easier. And then any kind of spreads also will make it go down a lot easier. Certainly you can have food and have liquid, drink something like that, but now you're managing a liquid which is going to go wherever it wants, alongside food that you're trying to keep from not going down the wrong pipe or not going past your defenses. And so sometimes putting a condiment on there gives you that moisture without necessarily making it too difficult to manage. Those mixed consistencies, like a bowl of Cheerios, especially if they're still crispy. Now you got food and crunchy stuff, and then you got liquid, and you got to manage them, and that's harder. This is a way around that. Again, I don't want to get too far over my skis, when I start getting into the world of occupational therapy. I do some lectures with a wonderful occupational therapist based in Louisville in Colorado, Nancy Hilmer. And so, again, this is kind of realm where I would ask Nancy where to go for this. But foods that you can eat in polite society with your hands, that would be a good option to make it easier at meal times. And so you would have any kind of cheeses. You could have any kind of fingery foods like fruits or olives or something like that. We eat a ton of olives over here. And then if you're having a sandwich, or you're having a hot dog, or you're having a hamburger or something like that, breaking it down and cutting it into finger sandwich size can be very helpful as well. So those are the ways I would modify the diet and do it in a way that's tastes good, that is enjoyable, that's not so heavy and not so. I think the worst thing you can do is take a food that you really love and then puree it, or turn it into something that, and if you like pate, God bless. But if you don't, take a different route and find foods that taste the way that they're supposed to in their naturally softer condition. Now, I saw someone coming in here on the chat asking about exercises that would focus on bite strengthening. So let me make sure I'm reading it properly. Yeah, biting strength. Yeah. So I think that if you're not able to bite the food off, like if you're taking a bite of an apple and you can't get through that, first of all, apple's a pretty tough one. That's definitely one I would cut. So bad example. But if you're having a harder time with that, I'd be looking at some of the factors around that, because that could be something where, is that happening all the time, or is that happening when you're eating, when maybe your meds aren't quite as on as they were, maybe you're at the end of your medication cycle? Because sometimes, I won't say sometimes, frequently we find in Parkinson's that the underlying strength's pretty much there. That's why when you work with a speech therapist and they can tell you to do loud ah, and they can prime you, and you're doing loud ah. And we find that also with leg strength, and the weakness comes from lack of use, not lack of capacity, where someone who's had some kind of stroke or something like that, the side that's infected by the stroke, there's no capacity there. The neurological connections, the neurons aren't firing, and they're not going to get the movement. So if you're legitimately not able to bite hard enough, then I think, again, that's a referral to a speech therapist. Have them give you specific exercises. The stuff we used to do when I first got out of grad school, we don't do at all anymore. We used to do stuff like you're sticking your tongue out and pushing against tongue blades and stuff like that. There's very specific reasons why you would do that, but not as many. Most often we do exercise for swallowing by doing swallowing, by building that. So again, if you're having an issue where you can't get enough bite strength, I want to know more about that, and I think you should work with an SLP one-on-one rather than be throwing some exercises, because I could miss a lot of stuff without seeing you in person. And again, some of that could be medication related. There could be some other factors involved there. And then again, you may get to a point where you do a bunch of exercise, but sometimes you're tired and you're not feeling 100%, and that's when you're going to want to bring in food that you've made a little bit easier to eat, so that you don't have to chew through a pork chop or an apple or whatever. So keep it coming into the chat. I'm keeping my eyes on both of them here, so I don't think I'm going to miss anything, but I'll keep my focus on both. Okay, let's talk about how you're going to improve meal times. And I think this is something that I don't think we get enough focus on, because I think we're very focused on evaluation and making sure that we have the strengthening we need or the activities we need. But I think that at a mealtime is the most important event of the day, several times a day. It's one of the more important social situations, and you often do it with friends and family if you're out, or at meal times during the holidays. And there are factors involved with the actual swallowing function, which we talked about there, the strengthening or the choice of the foods. But just as important is some of the things that happen in a meal environment. So you're trying to get food in while you're carrying on a conversation. So now you have to try to talk while you're let me make sure you got this here. Now you got to try to. So you're at a mealtime and you're trying to carry on a conversation while you're getting food in. That can be very dicey. So if you're in that situation, you want to be careful about getting engrossed in a conversation while you're trying to actually talk, because it makes it really easy for you to inhale something or not chew it completely, or try to rush some liquid down there so you can get your point in there. So that's one thing to be careful about, slowing it down. Also, though, if you're in a larger mealtime setting, maybe you got more people there, multiple conversations going on at once can be a problem, and then the noise becomes its own issue. And so a couple things that I think you should be thinking about when you're setting up a mealtime, whether it's in your home or whether it's out in the community, is finding ways to control the environment a little bit. So at home, you're turning off the TV, you're getting rid of distractions, you're making sure you got enough light so that if you are communicating at some point, you can see people pretty well. You'd be amazed what a little bit of low light or not being able to see someone's mouth can do to intelligibility. It makes a huge difference. And then if you're out and about, you're going to try to look for the part of the restaurant that doesn't have as many people, or maybe you can get a booth that's a little bit out of the way. And in particular, you don't want the booth that has your line of sight going where the servers are coming in and out of the kitchen, or where the bathroom is, because it's not just distractions from noise, it can also be visual distractions. And so if you can do things to to make it just a little easier to stay focused, and you don't have to contend with, alternating events for your attention. That'll make it a lot easier. When you're out in public with groups, it's nice, especially if you're with your care partner, if they can help facilitate conversations a little more global, so everyone can have something to say, but not everyone's expected to have their input all the time. And then if you're, again, with your care partner, you've probably done this already, a lot of you have, some cues for, like, hey, you want to take the turn, or maybe you want them to help you, but you don't want to say that. So you might have some cues. I remember we went, again, we're in Lisbon right now. We went to this very famous restaurant here with a couple of expats that we know. We have a couple of friends from different parts of the U.S. who now live in Portugal with Parkinson's. It's pretty interesting. It's a much different environment. I think you're probably getting better care in the United States, but that's another story. But the one woman's like, hey, this is a story that I've told many times, and it might just be easier if my husband helps a little bit on this, or so I don't have to spend so much energy on it, and I can spend more energy on something like that. Now, she told it to us because we're nerds and we're talking about Parkinson's, but you could probably have a way of doing that without having to explain it to folks, and then you guys can be a little more seamless. Again, I'll talk a minute about personal amplification. It's something I really reserve for really noisy environments, one-offs, if you're going to a holiday party or you're going to be someplace. And it's just a little speaker that has a little microphone that you wear. You can wear them full telemarketer style. I don't like to do that. I don't want to look like, can I take your order? But a lot of times you can just put them down here and have them under the neck, and then you keep it here, and when it's time to talk, you bring it up like this. I used to make actual recommendations for these, but now Amazon has made 7,000 versions, and so I try to find one that has a reasonable amount of good reviews, knowing that if it dies, that company's not going to be around. They go through a lot of them. It's not the kind of thing I would spend hundreds of dollars on, because you're probably not going to use it all the time, and most of the ones that are in that $30 to $40 range are going to be just fine. I will say, try to get one with a wired mic. I've tried all the ones with the wireless. They use a 2.4 gigahertz, like those old wireless phones, and they always break at the wrong time. So wired is a lot more secure. Just want to be careful on time. So I'll talk about this slide for a little bit, but we've covered some of this. I think this is just a nice set of guidelines, and obviously I'll be giving the slides to PAR, and they're going to put this video up on their YouTube channel, so you can see this a little bit later on. But when you're communicating, there's some habits that I think you can both get into. So if you're the person with Parkinson's, really focusing on your posture so that you're upright. That means you're going to have better breath support. You're going to be aiming your audio towards the person you're talking to, meaning aiming it towards their ears. If you're a little bit forward leaning, which happens sometimes, stooped, you might be aiming it down. And not only does that interfere with the audio, but it also means that they can't see your mouth as well as they want. And that's why you want to be as nice and upright as you can. I think, again, working with a speech therapist will be very valuable with this, but learning to just take your time, especially with people who know you and love you. You don't have to get in to fit in. You don't have to rush. And owning that, I think, actually gives you a little bit of self-confidence. But in addition, you don't feel like you have to rush and push through something. It makes you a much better communicator. I always, think about people you see speaking publicly. A lot of pauses, time to collect their thoughts. And if someone's trying to interrupt you, you can give them a little signal like, hey, I'm not done yet. And then if you're going to do a public meal somewhere out and about, finding foods that you can eat with your hands, again, in polite social environments, that's a good one. Sometimes if you're going to do something that might be kind of like a family gathering, a reunion or something like that, you might eat a little bit beforehand so you're not absolutely starving at the event, so that you can really focus on the connections with your friends and family and not, getting sustenance. Again, for the care partners, I think it's key when you're picking locations to get rid of distractions, and that's noise, but it's also visual distraction. So the first easy thing to do is just, if you got two chairs and one's facing the wall and one's out looking at the restaurant, facing the wall is always less distracting. And it also helps them hear themselves a bit better because you're bouncing the audio signal. It's like a mirror. Backlighting is a big problem too. So if you're in a big bright place and you got a window with sun coming in, that's going to take a lot of energy. And then adding in the communication aids we were talking. And then getting to the communication aids, it's hard to it's hard to overstate the influence of hearing loss and visual changes. And I'm not talking about Parkinson's related visual changes, which is a thing that happens, but just age related loss of hearing, age related changes in your vision. When you can't get the sensory information in well enough, easily enough, you spend energy you're leaning in, and then you're spending energy like really concentrating to be able to understand what's going on, and maybe you're missing certain cues that are happening. So this is one thing that's not related to being a speech therapist, but if you haven't done a basic vision exam lately or a hearing screening, it's worth it, because all the stuff I've talked about today takes time and energy, and you got to work with somebody, and you got to do the exercises, 5 times a day and all that stuff. This is the kind of thing where maybe a new set of glasses, maybe even a hearing aid, and now that we have over-the-counter hearing aids approved by the FDA, they've improved dramatically and they've become a lot cheaper. This is the kind of simple thing where you can actually change something very quickly, like a light switch, just by getting the right pair of glasses. And so don't underestimate that. I'm going to get into another area here. I'm going to say someone's got a question about probiotics, and I'm still going to wait. I will not ignore it. I will come to it, but I don't think it's right here. Okay, here's a very good question, and again, it's not quite swallowing, but I think it's something I can talk about for a second. Someone is the care partner for someone that they love, and the voice is changing, and it's getting softer and harder to understand, and that loved one doesn't want to do speech therapy. They're not interested. And the question that they have is there at some point where the therapy won't be as effective and it's a use it or lose it situation? And on the one hand, I always like to see people as soon as they can after the diagnosis. Use it or lose it, sure. It's easier to maintain function than it is to regain it. And if you had a situation where you've had a real step back for whatever reason. So that there's never a point where it won't be helpful, but I think it's much easier to keep it stronger and maintain it. And that's why I would recommend it. So I can't say definitively, like, no, if you didn't do it in the first 5 years, forget about it. Or if you had DBS, don't worry about it. DBS presents its own set of issues, but we can still do things. I think that what I'd be wondering is, where does the communication have an influence on your loved ones day to day? And that's where I start pointing, like, hey, you see how my favorite is when someone has a dog, especially an old dog that has bad hearing, but a dog, it's like the dog's not even hearing you, or you're not able to get what you need over the phone, or I can't go to a restaurant because you're so quiet, I can't hear you anymore. And I'm sure the first thing that'll come back is like, well, maybe your hearing's the problem. So it's like, again, that goes back to my slide here on screening. So I think you have to find a way to show them the benefits. But I will say that the treatment for quiet speech in Parkinson's, LSVT, loud or speak out, both of those have nice evidence, although LSVT's been around for a long time, incredibly effective. Absolutely will definitely make a change, and it's the kind of thing where even in a couple weeks you'll see dramatic. You'll see a couple sessions, you'll see it, but in a couple weeks you'll see robust changes. And I always love it when we do an online class and I can tell someone who's been seeing a speech therapist on the side, because all of a sudden they're so loud that they're dominating all the online answering. So I would say that yes, you should try to encourage them, but you're probably not going to be able to, like talking politics, you're not going to be able to logic your way. You got to show them where they're missing out. And again, maybe also another person with Parkinson's who's undergone that therapy might also be someone who could be affected, because I've very rarely had a situation where I've done that and the person's like, nope, don't feel any different. Usually it's a light switch, especially the first time. Okay, real quick, just want to talk about pills, because I think this is something that there's a lot of misinformation, I'll say, in the ether. I think a lot of people are doing different ways to address this. Again, pill dysphagia being the fancy term for swallowing problems. It's so common. It's probably the thing that I hear people complaining the most. And they'll say, "Oh, I don't have any swallowing problems, but except with pills." And it's like, well, that's the beginning. That's the swallowing problem. So let's address it now, so that you only have that issue, and we'll address it. And it's like the harbinger. And I think the first thing I want to say is that most times you take a pill and you get a glass of water, and you're trying to manage this pill, which is hard and solid, and maybe it has some edges even, and this liquid that's going wherever the heck it wants. That's usually difficult. And then people who throw their head back like this to try to help it, now you're helping. It means your tongue's not doing what it's supposed to do, and you're trying to facilitate it, but you're moving that liquid all the way past all your natural defenses. So that's the opposite. Kicking your head back with a pill is the opposite of what you need. And people have managed to do that successfully. People have managed to come up with a solution that does that, but you're putting things at risk. And I would say work with someone to find a better solution, or just consider getting a little bit of applesauce. You put the pill in the applesauce, and you have a bolus that's not too tight but compact, and it goes right down. Chewing up a little bit of banana, that's another easy one. I steer people away from cottage cheese or yogurt because there's protein in there, and some people are sensitive. The protein will compete with the medication for effect, where it gets absorbed in the duodenum. So applesauce is probably the gold standard. Okay, I heard a tip that works for me. Turn your head sideways when swallowing the pills. Why? Okay, so if you turn your head sideways, you're making the area smaller, and it might make it easier to compress the walls. That would be particularly if you had a stroke or some real deficit. Anyone can have Parkinson's plus a comorbidity like that, a co-occurring problem. And so you would tell someone to turn their head towards the side that's weaker, and that might help it. So again, there's a lot of stuff out there in the ether, and you may have come up with a solution. It's just one of those things where if you're kind of compensating now, if you have any kind of issues, if you get an infection or you get COVID or you get cold for a little while and your capacity goes down, your risk for getting a swallowing problem that causes pneumonia goes up. So it's like if you're holding your own, that's great. But if you could hold your own with the best possible options, it gives you more bandwidth for when a problem happens. And we all get, everyone gets a cold, or I have allergies every spring, especially over here. I'm not used to anything. Yeah, Forte voice training. Forte is actually kind of like LSVT. It's made for presbyopia. It's basically LSVT designed for non-Parkinson's, and it's just fine. No issues with it, except that I like something designed for Parkinson's. There's a lot of those as well, and I know PAR has an online program as well with somebody down, I believe, in the Springs. I'm just catching all these here. Crushing medication beneficial. Well, guess what? You read my mind. Yes, it is. That's another thing, is that many medications can be crushed and mixed with applesauce or other puree. Some of them are even available in a dissolvable format. And so, like the new Rytari, it looks just like this. It's like Contact. I mean, we're old enough to remember that commercial from the 70s, the cold medication. They open up and all the balls come out. So that one you can actually open up the capsule and put it into applesauce and have no trouble. There are controlled release and extended release formulations of medications where you can't crush them. So you should probably talk with the doctor or the APP, the nurse practitioner or physician assistant or whatever, just to make sure that you're not taking a med that if you crush it, it's not that the med won't be effective, but it will no longer be extended release. You get it all at once. If you're taking a slow-acting pill and you turn it into a fast-acting pill. But many of the regular Cinemets and the dopamine agonists can be crushed without an issue. Another thing that's coming more and more online, we've had patch formulations like a Nupro patch or Tigotine, but now there are pumps that are what are called subcutaneous pumps. So you put a little needle here and it delivers a continuous one. And AbbVie recently had a formulation approved by the FDA that's exactly that. There was another one from Israel that was also doing that, but AbbVie allows you to go to like 50 pills a day equivalent, so they're probably going to win. So that might be another thing, is to talk to your doctor about other options that aren't oral. There are some ones that are dispersible or dissolvable as well, but not many for Parkinson's. I'm thinking of like Eldepril or something like that. Okay, one last thing here, and this just came from a question here, and then I promise the person who's talking about probiotics, I will not ignore it. Drooling, sialorrhea is the technical term, except that's not quite true, because sialorrhea means excess saliva, and you're not actually producing excess saliva. Typically what's happening is you're not managing the saliva. So people with Parkinson's, you don't blink as much, is why sometimes you have dry eye. You don't swallow as often, and that's why you have drooling. It's not really drooling, it's just you don't manage the saliva in there. You might notice it first when you're waking up in the morning with a little bit of wetness on the pillow. It's a really common reporting that I say, oh, drooling, we can address it. Now, there are ways to address it. I used to work quite a bit in this, where I would do this work with somebody to help remind them. We would put a little timer on, we would do our regular speech therapy, and every time the timer came on, I would train you to remember to swallow more frequently. And that's effective, especially early on. It does require some attention, and later, you know, if you've had it for a while, that might take more attention than you want to spend on it. There are also some medications that your doctor could give you that will dry things out, whether it's atropine or glycopyrrolate or some of the other ones. However, I'm going to be real careful about this. Just because I go to all the conferences and I see a lot of stuff, I think botulinum toxin has made huge gains, and you know, not too long ago, 4 or 5 years ago, the FDA approved one called Xeomin, specifically for drooling and Parkinson's. And what I like about this, it's a shot. They deliver it to your saliva glands, usually the parotids, and sometimes one of the sublingual glands or something like that. And it'll dry things out a little bit, not too much, but it just slow things down. And what I like about it, it takes a week or so to kick in, and then it lasts for several months, and you can go back and do it again and again. So that's kind of, I'm not trying to take myself out of the game. I will be happy to help someone with that, or get someone set up on an app where you can use this to prompt yourself. But doctors, movement disorder specialists particularly, because they see it a lot, are pretty good at this. You can also keep little tricks, like you can keep a wristband, a terry cloth wristband, keeping your mouth busy if you're out going to the bank or something like that, and you just need to keep yourself a little busy so you don't drool there. A little bit of non-mint chewing gum is good. Ice cubes are good. Reason why I don't like mint, why I point you towards like a cinnamon or something like that, is that mint tends to relax esophageal sphincters and make it more likely to have reflux. And then your care partner can give you some cues as well. So I want to come back real quick to this individual. And again, this is not really a swallowing question, but someone was asking specifically about a probiotic. And a probiotic improves the flora and fauna in your stomach. It probably improves some components of digestion. And we know for sure that people with Parkinson's show differences in their flora and fauna, in the bacteria in their intestines in particular. And we don't know if that's caused by the Parkinson's or a result of the Parkinson's, but we know it's different. There was a really interesting study in one of the Nordic countries where they had people who used to do vagotomies. They cut part of the vagus nerve, and it would improve that as well. We used to do that for ulcers. We don't do it anymore. So we know there's something going on there where maybe something's traveling in that respect. And the thing is that there have been a couple of studies for a probiotic to improve Parkinson's in the short term, and usually it's improving, like motility, like constipation or diarrhea. But the thing I've noticed is that I'm on the scientific advisory board for Davis Finney. We funded one with Mark Haub in Kansas, and that was an off-the-shelf one. And there's one called Simprove in the UK, and that's another off-the-shelf one. And that study was done by Ray Chowdhury, who's a brilliant, world-famous neurologist. And so what I typically say is that it might provide some benefits, some short-term benefits particularly. I don't know if you're going to take a probiotic for the rest of your life, but you might take it for benefits on occasion, take a course of it. But it doesn't seem to show any benefit for a specific custom design for Parkinson's or custom probiotic, artisan probiotic. There may be some artisan probiotics that have better quality materials. That's a different story. But it seems that the research is consistent on the benefits of just an off-the-shelf one. It would be worth talking to your doctor to see if they have a preference or an idea. I would say watch this space. We're going to have better information in that area in the future, but we just don't now. And at this point, it's like I wouldn't spend a lot of extra money on something fancy, but they're expensive enough. But I also would be interested in knowing how long your doctor thinks you should take one, because I don't think anyone's going to say take a probiotic for the rest of your life. I don't think the research is there yet. Watch that space though. So, okay, let me just sure I'm missing any other questions. Does anyone have anything? I know I'm just about over time here, so I don't want to abuse my time here. Does anyone have any thoughts? Okay, PAR's really great. I give them the video. They'll have this up in just a couple days, and they'll have the slides. If you reach out to PAR, you can go to info@parkinsonrockies.org, and they'll pass on any questions to me. I'm happy to answer stuff over email. And otherwise, I hope you guys will join us next month. My wife, the brilliant physiotherapist who just got her PhD with Boss Bloom, will be talking. Oh, yes. That's another one here. Someone talked about doing goat milk kefir. And I do think that getting sources of fermented materials is another way to bypass the probiotics. And I think the benefit of doing it with food materials is you also get fiber and you get a lot more complex stuff. So I think that's a really good idea too. I think in January I did one on diet, and I think I might have gotten into probiotics more there, so you can look on their YouTube channel. So, all right, folks, thanks for coming in. Have a great one, and I really appreciate you joining me today. And thank you to the Parkinson Association of the Rockies for underwriting everything and making this happen. Thank you, Jody. Good night.
Thank you.